probably should keep going. It's 7:30. Good morning and welcome to the Wednesday morning rounds. I would like to introduce Dr. Joanne Joseph. She is a fellow in our adult echocardiography program, and she is talking about acute care of adults with congenital heart disease. She'll give us some clinical pearls. And for attending online, if you're attending online, just please submit your questions in the Q&A or the chat box, and don't forget to sign the attendance sheet, please, after the presentation. Thanks, Joanne.
Thank you so much, Dr. Aiden. So good morning, everyone. Thank you for the opportunity to talk to you today. I'll be speaking about acute care of adults with congenital heart disease in the inpatient setting. Through case-based approach, we will highlight some of the important clinical pearls in congenital care and review the new ACC/AHA 2025 guidelines where applicable. So as you know, 1 in 100 children are born with congenital heart disease, making it the most common congenital malformation globally. And this can exist in a spectrum from simple PDA to complex conotruncal defects. So why is congenital care important? Thanks to major advances in diagnostic and surgical techniques, more than 90% of children are currently surviving into adulthood. And this is compared to 15% in the 1940s. So globally, and especially in high-income countries like Canada, there are currently more adults with congenital heart disease than children. Mortality in congenital heart disease has significantly declined, especially after birth in the 1975 for patients due to advancement in surgical techniques. In spite of this reduction in mortality, patients with congenital heart disease actually continue to have significant mortality, which is 3 times higher than the general population, even when adjusted to common cardiovascular risk factors such as hypertension and diabetes. And this increase in mortality is actually persistent among all patients with congenital heart disease, irrespective of the type of defect they have. The more complex the congenital heart disease, the more likely they are to die from it. So to put this into perspective, this is a table from the Brompton ACHD group in the UK, which compares the life expectancy of adults with congenital heart disease to that of the general population. As you can see, if you take a 20-year-old patient with ASD, their life expectancy is slightly reduced and is comparable to an average 25-year-old. However, if you take a 20-year-old patient with Fontan palliation, their life expectancy is actually significantly reduced and is comparable to a 64-year-old patient from the general population. So an important reason for this increased mortality is the high prevalence of acute illness and hospitalization among patients with congenital heart disease. It's not surprising that the rate for hospital admission among patients with congenital heart disease is continuing to rise. And it's mainly because our patients are getting more older and more complex. And the current rates are about 2 to 3 times higher than the general population. The most common cause for admission include heart failure and arrhythmias. So therefore, it's extremely important that all cardiologists become comfortable in caring for patients in the inpatient setting. And for the rest of the presentation, we will focus on developing an approach for caring for these patients in the acute care setting. So I would like to propose a simplified approach, which I call the ABCDE of congenital care. So let's start with A. It stands for anatomy and physiology, which is essentially understanding the complexity of the anatomy, whether it's simple, moderate, or great complexity, understanding if it's been repaired or not, and if repaired, if there's any residual defect left. And physiology is essentially understanding the clinical implications of this congenital defect on the patient, whether they're symptomatic or asymptomatic from it. The ACC/AHA guidelines have an extensive list of anatomic and physiologic classifications, but to simplify it, it's been summarized here. The main takeaway point is that two patients with the same anatomy can have different physiologic states. For example, if you were to take a patient with tetralogy of Fallot who's considered to be moderate complexity lesion, they could be physiologic stage A with no symptoms or develop refractory arrhythmias and become physiologic stage D. And patients can actually move between the different physiologic states. Understanding the interaction between anatomy and physiology is important because it helps us risk stratify our patients and guide management. And one way to understand native anatomy a little bit better is through a process called sequential segmental analysis. Due to constraints in time, I won't be going through it, but it simply means that we look at the heart in separate segments, understanding the heart as the atrium, the ventricle, the great arteries separately, as well as the connections between them. It gives you a way of understanding different components to simplify it a little bit better. For example, if you're thinking about the ventricle, understanding if the morphologic right ventricle is on the right side of the patient or the left side of the patient. Because if it's on the left side and becomes the systemic ventricle, it's more likely to be dysfunctional and the patient is more likely to develop heart failure. The next part of the approach is B, for baseline oxygenation. As we know, hypoxemia is oxygen saturation less than 92%, and when clinically significant can manifest as cyanosis. However, cyanosis may not be apparent in all of our patients who are anemic. And there are many reasons why patients can become hypoxemic, including hypoventilation, VQ mismatch, diffusion limitation, and right to left shunt. In the congenital world, the most important cause for hypoxemia after ruling out pulmonary edema and pulmonary pathologies is right to left shunt. And one quick way to delineate between right to left shunt and other etiologies of hypoxemia is to look at their response for 100% FiO2. Patients with right to left shunt will not improve their oxygenation or will not normalize with high flow oxygen, whereas those without a right to left shunt tend to have a significant improvement. And we classify congenital heart disease based on oxygenation as cyanotic and acyanotic lesions. Patients with a right to left shunt are considered to be cyanotic, and those without a right to left shunt, meaning the absence of a shunt or a left to right shunt, are considered to be acyanotic. Patients with cyanotic heart disease post repair can actually become acyanotic by improvement in their oxygenation. And this is important because understanding if your patient is cyanotic or acyanotic can help you decide on oxygen target as well as need for oxygen supplementation. C stands for cardiac complications related to congenital heart disease. And depending on the type of congenital heart disease, patients can have a variety of complications, including atrial or ventricular arrhythmias, heart failure, pulmonary hypertension, thromboembolism, infective endocarditis, coronary stenosis, to name a few. And these complications, understanding them well, will help us to be more vigilant, anticipating them and acting on them pretty early. D stands for don't forget about non-cardiac issues related to congenital heart disease. And this is important because patients with congenital heart disease are at increased risk of developing chronic multi-system illness, including renal and liver dysfunction. So paying attention to non-cardiac issues and treating them early is important. And then final part of the algorithm is E, which stands for ensuring adequate follow-up. Both the American and the Canadian guidelines are clear that no matter the complexity of the congenital heart disease, everyone must be seen by a congenital cardiologist at least once in their lifetime. And everyone other than a simple asymptomatic patient should be followed by a congenital program lifelong. So it's very important that when we arrange for follow-up, that we ensure that the patients receive the adequate follow-up that they need. And in addition to part of our inpatient care, when we're discharging patients, it's also important to identify those at risk of endocarditis, those who need contraception counseling, those who need activity restriction, and implementing those early lifestyle changes in our patients as we discharge them from the acute care in the inpatient setting. In spite of our guidelines, emphasizing the importance of regular congenital follow-up, more than 50% of adults with congenital heart disease are actually lost to follow-up and are not part of a congenital program. At the Heart Institute, we've taken steps to minimize this by creating a transition program, which is run by our nurse practitioners, where we review all patients who come into the program, whether they are referred from the community or from the Children's Hospital, to ensure that they're linked to us very quickly so that we can identify those who are at risk of deteriorating and developing symptoms early so that they can be taken care of in a timely manner. So there you have it. That is my ABCDE approach to congenital care. And for the next little bit of time that we have left, we will approach 3 patient cases to see how we can apply this approach. So case 1. So this is the case of a 46-year-old male with DeGeorge syndrome, post-tetralogy of Fallot repair. He presents with shortness of breath on minimal exertion with leg edema. Chest X-ray shows evidence of pulmonary edema, and his oxygen saturation is 90%. He initially had a transannular patch and VSD repair for his TET at the age of 3 and subsequently developed pulmonary regurgitation that was severe, needing pulmonary valve replacement. This is a presenting ECG that was interpreted as sinus rhythm with right bundle branch block and first-degree AV block. So if we apply our ABCDE approach to congenital care, the first is understanding anatomy and physiology of our patient. So tetralogy of Fallot is a moderate complexity defect, and given that the patient presents with exertional symptoms, we would classify him as stage 2C. And what is tetralogy of Fallot? It's essentially a malposition VSD where the septum, oh, you can't see my pointer, where the septum is actually abnormal, and because of that defect, the anterior part of the septum sort of bulges into the right ventricular outflow tract, and that causes crowding of the right ventricular outflow tract with underdevelopment of the pulmonic valve. This increases the afterload, therefore the right ventricle hypertrophies, and as part of this VSD, the aorta overrides into the right ventricle. And therefore, that's why it's named the tetralogy of Fallot, due to the 4 different components. And this patient underwent something called a transannular patch, where they dissected the pulmonary artery and the pulmonary valve to be able to relieve the right ventricular outflow tract obstruction, which has subsequently led to the development of pulmonary regurgitation, and the VSD was patched with the very pericardial component. And then finally, because of that transannular patch, the patient developed significant pulmonary regurgitation that's been eventually replaced with the pulmonic valve. So then when we think about residual defects, the patient had an echocardiogram a year ago which showed mild LV dysfunction and moderate RV dysfunction as well, but the pulmonary valve itself is functioning well without any residual VSD. On repeat presentation, his LV function has declined to 35%, his RV function is stable, and there's mild elevation in pulmonary vascular pressures. So now that we've understood his anatomy, we could move on to understanding his baseline oxygenation. We know that this patient with repaired tetralogy of Fallot should not have a residual lesion, which means there's no shunt, so this patient is acyanotic. So we expect his oxygenation to be normal. So the mild hypoxemia that we see on presentation is secondary to the pulmonary edema noted on chest X-ray. So with diuresis, we would expect his oxygenation to normalize. So in this patient, we would give supplemental oxygen if his oxygenation was to drop below 92% and wean off oxygen as he gets diuresed progressively. And next is understanding complications related to congenital heart disease. And in patients with tetralogy of Fallot, there are multiple cardiac complications that we should anticipate, including pulmonary regurgitation from the transannular patch, which leads to RV dysfunction and significant TR. There's also risk of developing residual VSD and RVOT obstruction, LV dysfunction, aortic dilation, as well as ventricular arrhythmias. So when we take a look at our patient more closely, he has moderate LV dysfunction and decompensated heart failure, and has elevated pulmonary pressures due to pulmonary congestion. Thankfully, his RV function hasn't changed. There's no valvular dysfunction that's new, no evidence of infective endocarditis. His pulmonary valve is working fine. There's no residual RVOT obstruction, no residual shunt. So why is our patient now presenting in heart failure? So if we go back to our ECG that was initially felt to be a sinus rhythm and we take a closer look at it, you can see that the P waves in lead 2 are negative. And this is because of an atrial arrhythmia called intraatrial reentrant tachycardia, and he's currently going at a rate of between 90 to 100. So what's IART, or intraatrial reentrant tachycardia? It's a scar-related macro reentrant circuit that includes both typical flutter that involves the cavo-tricuspid isthmus, as well as atypical flutter that does not involve the cavo-tricuspid isthmus. And because congenital patients can have anatomical variants of the cavo-tricuspid isthmus, it's hard to name something typical or atypical most of the time. So these terms are lumped together under an umbrella term to call them IARTs. And they're different from AFib and atrial tachycardia, which are micro reentrant circuits. IART tends to be regular with the heart rate ranging between 90 to 120 and are usually slower than other arrhythmias, especially in congenital patients who may have a ton of scar in their atrium, and is often mistaken for sinus rhythm. So it's very important to compare their baseline ECG with their presenting ECG. In young patients with congenital heart disease, IART is the most common arrhythmia, and the prevalence for atrial fibrillation increases as the patient ages and surpasses IART at the age of 50. So we manage IART just like atrial fibrillation. We think about rate versus rhythm control, acute anticoagulation, and long-term anticoagulation in these patients. And in patients with congenital heart disease and IART, rhythm control is preferable because congenital patients tend to be most sensitive to arrhythmias and can develop decompensated heart failure very quickly. Of note, when we consider cardioverting these patients, it's important to pay attention to the cardiac position because patients can have dextro position when the heart is located in the right side of the heart. They can have dextrocardia where the apex is pointing to the right side. So ensuring that you know the cardiac position is important, and a chest x-ray can be super helpful. And based on that, you can place the pads so that the maximum amount of electricity passes through the heart during electrical cardioversion. Another point to take note is that many patients have devices and not placing the pads on top of the device, but being at least 3 centimeters away when you cardiovert patients with devices. So second is acute anticoagulation. We are all familiar with the CCS AFib guidelines regarding timing of anticoagulation, but this does not apply to patients with congenital heart disease. In summary, what we could say is, if a patient with congenital heart disease is stable and is presenting with IART, you should always consider anticoagulating patients with either greater or moderate complexity lesion. Only patients where you could consider cardioverting right away are patients who are simple lesions without any significant complications. And so if a patient like our patient who is moderate complexity lesion shows up, you should have a TE-guided cardioversion or consider anticoagulation for 3 weeks before you can cardiovert them. This is different if the patient is hemodynamically unstable and you need to cardiovert them right away. And let's say if it's anyone else who is a simple cardiac lesion, who does not have any complications otherwise, then you can follow the CHADS algorithm, like our CCS AFib algorithm, to go ahead and cardiovert these patients. So how about long-term anticoagulation? Once again, CHADS 65 algorithm does not apply to these patients. Essentially, all patients with moderate or greater complexity lesion must have long-term anticoagulation. And for those with simple lesions, if they have a mechanical valve, if they have moderate to severe AV valve stenosis, then they should also be anticoagulated long-term. So only simple congenital defects with low CHADS-VASc score of 0 do not need long-term anticoagulation. So what type of anticoagulation is actually safe in patients with congenital heart disease? Vitamin K antagonists like warfarin is preferred in patients with mechanical valve, those who have had cardiac surgery in the last 3 months, and those with significant AV valve stenosis. And there are currently no randomized studies comparing vitamin K antagonists like warfarin to DOACs in patients with Fontan or cyanotic patients. There are some smaller studies and meta-analysis that say that these are comparable, but the guidelines say vitamin K antagonists like warfarin tend to be preferred over DOAC due to the lack of evidence. So in our patient who is acyanotic, moderate complexity lesion, we know he needs cardioversion. We need to do TE-guided cardioversion, and he will need long-term anticoagulation, and DOAC is safe. So he undergoes TE-guided cardioversion, and this is the ECG that we get. And as you can see, if we compare it to his presenting ECG, his P waves are upright in lead 2 compared to his presenting ECG with negative P waves in lead 2. So next is understanding why the LV dysfunction occurred. We've identified an arrhythmia, which is the likely cause for the LV dysfunction, but don't forget about other causes of LV dysfunction that we think about in non-congenital patients. So if we apply all of that to our patient, we think about, valvular disease. He didn't have any significant valvular dysfunction. His pulmonic valve is functioning well. There's no evidence of coronary stenosis on CT cardiac. There's no history of long-standing hypertension, no toxin exposure, no metabolic abnormalities. His device check shows that there's no significant pacing burden to cause pacing-induced cardiomyopathy. So putting all together, we can say the patient likely has tachycardia-induced cardiomyopathy for his drop in LV function. And with the treatment of IART, we expect it to improve. And why did our patient initially have mild LV dysfunction at baseline? It's something that we see commonly. It's mainly because of fibrosis of the left ventricle, post-surgical myocardial injury, and even electromechanical dyssynchrony related to the right bundle branch block are all causes why tetralogy of Fallot patients tend to have mild to moderate LV dysfunction. So the next step is D, don't forget about non-cardiac issues. Our patient has DeGeorge syndrome and is at increased risk of parathyroid and thyroid abnormalities. And although amiodarone is not contraindicated, it should be used cautiously. So in our patient, when we ensure follow-up, we're going to follow his TSH and liver enzymes a little bit more closely, 3 months instead of 6 months. We're going to anticoagulate him, put him on GDMT, repeat an echo. And in this patient's case, his LV function improved to his baseline EF of 45%. And since he has a prosthetic valve, he should have antibiotic prophylaxis in the long run. And we counsel that to the patient and connected him to the congenital clinic for long-term follow-up. So as a takeaway from this case, have a low threshold to look for arrhythmias such as IART in congenital patients who present with heart failure. Always compare their presenting ECG to the baseline ECG. Absence of a fast rhythm does not mean absence of an arrhythmia. These patients tend to go slower and may even go at a rate less than 100. So always compare it to their baseline ECG. And you prefer rhythm control in these patients, and TEE-guided cardioversion is what we do, or anticoagulate for 3 weeks. The only patients who are safely cardioverted without any of those are simple congenital regions who present ALE. Anyone with moderate or greater complexity must be anticoagulated or TE-guided cardioversion. And then chest X-ray can be helpful with pad placement like we talked about, and the CHAD65 algorithm does not apply for long-term anticoagulation. Moderate and greater complexity lesion must be anticoagulated long-term, and the only patients who do not need it are simple congenital lesion with the CHAD score of 0. I'm going to take a sip of water, and then I'll keep going. So next is case 2. So case 2 is a 71-year-old female with unrepaired patent ductus arteriosus with secondary Eisenmenger syndrome. She's presenting with palpitations and an ECG showing AFib. She's on bosentan for Eisenmenger, and her hemoglobin is 190. So we start with our ABCDE approach, understanding the anatomy and physiology. Although PDA is a simple lesion, development of cyanosis and Eisenmenger syndrome is considered to be stage D functional classification. An unrepaired PDA initially causes a right to left shunt from the aorta into the pulmonary artery. But if a PDA is large enough, significant flow into the pulmonary vasculature can lead to negative remodeling, increase in pulmonary vascular resistance, and eventual development of pulmonary hypertension. And when the pulmonary pressures exceed systemic pressures, there's reversal of flow where blood can go right to left, leading to Eisenmenger syndrome. So to have Eisenmenger syndrome, you need a shunt that's unrepaired with development of pulmonary hypertension. So, and then when we think about baseline oxygenation, patients with Eisenmenger syndrome have a right to left shunt at the level of the PDA. And this means they present with something called differential cyanosis, where they develop cyanosis and clubbing in their toes and preservation of their fingers. So when you think about oxygen saturation, you should check their toe saturation and not their finger saturation. So the overall oxygenation should be determined based on toe saturation. And it's a common mistake that we see in the inpatient setting. And when you speak to your nurses, ensuring that the toe saturation is checked. And when do we decide on oxygenating these patients? The guidelines are clear that patients with chronic cyanosis do not have a target oxygenation because no matter how much oxygen you're going to give them, you will never normalize them. So instead of targeting a specific oxygenation, the criteria for oxygen supply is based on symptoms. Let's say a patient is 85%, but completely fine, asymptomatic, you leave them alone. You don't give them any oxygen. So our patient, although she presented with atrial fibrillation, otherwise she was not short of breath, she was feeling fine. We tolerated a oxygen saturation of 88% and did not give her further oxygenation. So a quick word on right to left shunt. So presence of a right to left shunt does not always mean pulmonary hypertension. You may have a right to left shunt in the case of streaming through a PFO, especially if you have a prominent eustachian valve and develop orthodoxy of platypnea syndrome in the absence of pulmonary hypertension. And when you have a right to left shunt in the presence of pulmonary hypertension, the question becomes which came first. You may have pulmonary hypertension as the primary disease and then pop open a PFO or a pulmonary AVM to relieve the pulmonary pressures and therefore develop right to left shunt. Or you can have a shunt that's significant enough, like a Eisenmenger syndrome, and eventually develop pulmonary hypertension. So it's sometimes very difficult to differentiate between which came first, but most of the time, if you have a shunt leading to pulmonary hypertension, imaging modalities will help you identify ASD, VSD, or PDA a little bit more easily. So moving on to cardiac complications is that it's clear that patients with unrepaired shunt develop pulmonary hypertension, just like in the case of our patients. And this is because of increased pulmonary vascular flow, which leads to initially reversible pulmonary hypertension and then irreversible pulmonary hypertension and eventually Eisenmenger syndrome when the pulmonary vascular resistance exceeds that of the systemic vascular resistance. So when is it safe to intervene on these shunts? For this patient who presents to our hospital in AFib, should we go ahead and close this PDA? And the question is no. The guidelines are clear that the ideal patient who we should think about closing a shunt should have absence of pulmonary hypertension or pulmonary vascular resistance that's less than 1/3 of the systemic vascular resistance. Once your pulmonary vascular resistance exceeds 2/3 of the systemic vascular resistance, or the patient's developed Eisenmenger syndrome, the risk of closing a shunt is actually higher, and this can cause RV dysfunction and heart failure in our patients. So once you have Eisenmenger syndrome, you should not be closing the shunt and should be managing these patients symptomatically. So if repair is not an option for our patients with the Eisenmenger syndrome, then how do we treat them? Guidelines say that if you have Eisenmenger syndrome, first thing is to do a invasive right heart cath to confirm the presence of pulmonary hypertension and to rule out anything that is reversible. So once you confirm Eisenmenger syndrome, you can refer them to pulmonary hypertension clinic, and you could and there they could be initiated on pulmonary hypertension therapies as long as their LV function is above 40%. If a patient is unlucky to have Eisenmenger syndrome and LV dysfunction with EF less than 40%, unfortunately, pulmonary hypertension therapies can actually be detrimental because now you're overloading and increasing preload to a dysfunctional ventricle and are at risk of precipitating heart failure even further. So what do we do for our patient? Her pulmonary pressures haven't changed from her baseline. She's otherwise feeling well. We continue her bosantan, and we do not need to add any additional therapies. And we do not close her shunt in the inpatient setting or ever. So next step is don't forget about non-cardiac issues related to congenital heart disease. Eisenmenger syndrome and chronic cyanosis has many complications outside the heart. And first one is called secondary erythrocytosis, which is essentially elevation in hemoglobin that can precipitate hyperviscosity syndrome. This is because the patient produces higher amount of hemoglobin to try and supply oxygen in the context of chronic hypoxemia. But the problem is that with elevated number of red cells, you can develop something called hyperviscosity syndrome, where the red cells can go in and clog up small arteries. And with high turnover, these patients are at high risk of developing iron deficiency. Even if their hemoglobin is 190, patient may still have iron deficiency. And an iron deficient red cell is even more sticky and can go in and clog up smaller arteries. So, and patients with hyperviscosity can present with headache, blurry vision, dizziness. So let's say this patient was to present with any of the hyperviscosity syndrome. The guidelines say that always get a CT head to rule out stroke, because these patients are predisposed to stroke from the hyperviscosity syndrome. And after you rule out stroke, if you think it's small arteries being clogged up, you can treat them with IV fluids and oral fluids, identify iron deficiency and treat it. And in spite of treating iron deficiency and IV fluids, if they continue to be symptomatic, consider phlebotomy if their hematocrit is above 65%. The guidelines say do not consider prophylactic phlebotomy. So if you have a Eisenmenger patient presenting with hemoglobin of 190, do not do bloodletting prophylactically, because this increases risk of iron deficiency and increases risk of stroke in these patients. And an opportunity for us is, if we admit an Eisenmenger syndrome, is to screen our patients for iron deficiency. And the guidelines say these patients should be screened annually for iron deficiency. And if you identify it, start them on iron supplementation. So the second issue with congenital chronic cyanotic patients is coagulopathy. These patients can bleed and clot at the same time. And when they bleed and clot at the same time, it can be disastrous. Their arteries can be dilated and have low flow, which increases their risk for pulmonary embolism. They also have leaky vessels that can bleed and cause pulmonary hemorrhage. So for this reason, anticoagulation in patients should be very, very cautious. In spite of their high risk of clot formation, we do not prophylactically anticoagulate these patients. Only patients with arrhythmias or thrombus should be anticoagulated after ensuring they do not have significant risk for bleeding. So in our patient who presents with atrial fibrillation, it should be a close discussion with the patient about risks of bleeding and stroke risk. And since her risk of bleeding was thought to be low, she was anticoagulated. And the type of anticoagulation in cyanotic patient is warfarin over DOAC. And one quick note about monitoring INR in warfarin in chronic cyanotic patients is that if you have a patient with a hematocrit above 55%, you should be careful about measuring INR. And this is because of the anticoagulant content in the INR tube itself. It is sort of balanced to the average amount of plasma volume. But if a patient who has secondary erythrocytosis and the hematocrit is above 55%, the plasma volume will be a lot lower. So you have to speak to the lab to ensure that the INR tube is adjusted for the right amount of citrate anticoagulant for the low amount of plasma volume that the patient has, to determine the right INR measurement for these patients. Because if you have a patient who's admitted with Eisenmenger syndrome and you have an INR that's elevated, do not trust that blindly. Always check, double check and triple check with the lab to ensure the right INR measurement was done. So how about other complications of chronic hypoxemia? Patients can have CKD, neurodevelopmental issues, and because of high red cell turnover, they can develop gallstones and gout. And one interesting factor is that patients with Eisenmenger have chronic proliferation of chromaffin cells and they're at risk of developing pheochromocytoma. So if a patient like this presents with difficult to control hypertension or difficult to control atrial arrhythmias, have a very low threshold to test them for pheochromocytoma. So you can do that with plasma metanephrines or 24-hour urine metanephrines to ensure that it's identified and treated if present. And everyone with a shunt, whether they have Eisenmengers or not, need a bubble filter. And that's one of the first things that I check in our patients, and making sure that they have bubble detectors, because if there is a paradoxical embolism, it can be detrimental to the patients. And then finally, if a patient needs a pacemaker, transvenous pacemakers increase risk of paradoxical thromboembolism. So we have discussions with our EP colleagues to decide on endocardial leads or subcutaneous leads instead of transvenous leads in patients with Eisenmenger or chronic cyanosis. So finally, E, in terms of adequate follow-up, this patient underwent TE-guided cardioversion, was started on amiodarone, once again with close follow-up, because chronic cyanosis is shown to have thyroid dysfunction in the context of amiodarone initiation. So again, their TSH level and liver enzymes are checked 3 months instead of 6-month duration. She was initiated on anticoagulation with warfarin, was referred to EP for ablation. Because she's an older patient, she did not require contraception counseling. But if it is a younger patient, then you would consider initiation of contraception, estrogen without estrogen because of the pulmonary hypertension that's present. And if they are contemplating pregnancy, it's a hard contraindication and WHO class 4 due to increased risk of maternal and fetal risks. And in terms of oxygenation, when we send her home, she doesn't need oxygen because she's comfortable at 85 to 88%. As long as she doesn't have any symptoms, we don't need to do anything. And we did not need to do phlebotomy in this patient. So let's say the same patient represents again, but this time with fever and seizures. What would you be concerned about? The first thing is endocarditis, endocarditis, endocarditis. But in cyanosis patients, it's also cerebral abscess, cerebral abscess, cerebral abscess. Do not forget to do CT scan in these patients, because what happens is that all of us are lucky because we have a lung circuit that has good alveolar macrophages that are able to filter out pathogens. But patients with chronic cyanosis and right to left shunt, they lose that intrinsic mechanism of filtering out pathogens from the blood because a substantial amount of blood is bypassing the lungs. And they're also at chronically deficient immunity. So both low immunity and bad lung vasculature and unable to filter makes them at risk of infections, especially cerebral abscess. So fever, headache, anything that's neurologic in your patient with chronic cyanosis or Eisenmenger syndrome, always get a CT and get a CT with IV contrast to identify cerebral abscess so that they can be treated very quickly with antibiotics and surgery. So take-home point for this patient is that Eisenmenger syndrome, not everyone needs a specific target oxygen. Look at their symptoms, and if they're asymptomatic, they may not need oxygenation. They do not need prophylactic anticoagulation. They do not need prophylactic phlebotomy. Only do phlebotomy after IV fluids, after ruling out iron deficiency, and if they're still symptomatic with a hematocrit above 65%. Use hospital admission as an opportunity to identify iron deficiency and starting them on iron supplements if needed. And always use bubble filters in shunt lesions, whether they have right to left or left to right. And if you have fever with neurologic symptoms, CT head with IV contrast to rule out cerebral abscess, and always think about blood cultures with infective endocarditis. And then finally, if you have a patient with Eisenmenger's, hypertension, atrial arrhythmias, think about pheochromocytoma and screen for them early. You guys aren't bored yet, so that's good. So case 3. The final case is a 50-year-old male with hypoplastic left heart syndrome with fenestrated lateral tunnel fontan. He presents with hypoxemia, shortness of breath, tachycardia, and pleuritic chest pain. His oxygen saturation at baseline at home is 90%, right now on presentation is 80% with a blood pressure of 100/70. His past medical history includes hepatocellular carcinoma. ECG shows sinus rhythm. His CTPA is negative for pulmonary embolism from a community hospital, and he is sitting in front of you hypoxemic. So if we go back to our approach, we think about anatomy and physiology. So this patient has something called hypoplastic left heart syndrome, which is essentially underdevelopment of the left heart and usually associated with underdevelopment of the aorta. And therefore, they essentially have a functioning right ventricle that eventually becomes the systemic ventricle. So in terms of how do we treat these patients, the goal is to try and separate the systemic and the pulmonic circulation to be able to minimize cyanosis in these patients. And that's done in multiple stages. So stage one of this process is to ensure adequate blood flow to the lungs and the pulmonary circuit, and that's and the rest of the body, and that's done through a procedure called the Norwood procedure, where they combine the hypoplastic aorta as well as the pulmonary artery into a single vessel, and that supplies blood from the systemic ventricle into the rest of the body. And they create a shunt from the aorta to the pulmonary artery to be able to supply blood to the lungs. So that's stage one, done within few weeks of birth. In this stage, oxygenated blood and deoxygenated blood is still mixing, and the patient is cyanotic. Stage two is to remove this shunt that was created and to create a bidirectional gland, where the SVC is connected to the pulmonary artery in an attempt to supply more blood to the lungs and to try and separate the pulmonic circulation from the systemic circulation. Oxygenated and deoxygenated blood is still continuing to mix, and the patient is cyanotic. And then stage three is creation of the Fontan circuit, where you take the IVC and connect it to the pulmonary artery to completely separate the systemic circulation and the pulmonic circulation. The pulmonic circulation receives passive blood flow without a subpulmonic ventricle, and the systemic circulation receives active blood flow through a single systemic ventricle. And because of this setup, the pulmonic vasculature is dependent on low pressures and is at risk of low cardiac output when the pulmonary vascular resistance goes up. At this stage, once the Fontan circuit is created, the patient has completely separate pulmonic and systemic circuits, so they should not be cyanotic anymore unless they have other reasons to be cyanotic, which we will discuss next. In terms of the types of Fontans, there are three types of Fontans. So you have an atriopulmonary Fontan, where the atria is directly connected to the pulmonary artery to allow flow of the IVC into the pulmonary artery. You could have the lateral tunnel Fontan, which our patient has, where you have a separate tunnel within the atrium to direct blood from the IVC into the pulmonary artery. And then finally, you have the extracardiac Fontan, which is an external tube that connects the IVC to the pulmonary artery. Contemporary practice right now is to do lateral tunnel Fontan or an extracardiac Fontan. So this patient had an echo about a year ago that shows the systemic ventricle, in spite of his RV morphology, is functioning well. There is mild to moderate AV regurgitation. The Fontan is functioning well. And on presentation, his echo also confirms that the systemic ventricle is functioning well, and the Fontan itself is functioning well without any significant issues. So now that we understand his anatomy and physiology a little bit better and what the Fontan circuit looks like, then we can go on to understanding his baseline oxygenation. Based on what we've discussed so far, successful completion of Fontan means that the patient should have normal oxygenation. They should not be hypoxemic. But hypoxemia in Fontan circulation can happen for a number of reasons. Number one is acute hypoxemia. And this can happen because of pulmonary embolism or pulmonary edema. And chronic hypoxemia, that can happen because of development of veno-veno collaterals, development of pulmonary ABMs, and fenestration of the Fontan, which this patient had. So what is a Fontan fenestration? As you can see, the Fontan circuit itself has a little hole that allows blood flow from the Fontan circuit into the right atrium and the systemic ventricle through right to left shunt to allow increase in the systemic flow, but also to relieve pressures in the Fontan circuit. And because a fenestrated Fontan by definition has right to left shunt, these patients tend to have some level of hypoxemia, and that would explain why our patient's baseline oxygenation is 90%. But presence of a Fontan circulation with fenestration does not explain why he decompensated and is currently 80%. So that needs to be figured out still. So next is C. Fontan patients have many cardiac complications. One of them is atrial arrhythmias, especially in patients with a atriopulmonary connection because of their suture lines are more predisposed to to atrial and ventricular arrhythmias. Second, they can have systolic dysfunction of the systemic ventricle, especially in like our patient, if they have a RV morphology, it can become more dysfunctional because it has to pump against a systemic pressure and higher afterload. You can also develop diastolic dysfunction. Normal diastolic function is important in patients with the systemic ventricle because it acts as a suction effect to pull blood forward through the Fontan circuit. So if you have diastolic dysfunction in a patient with Fontan circulation, that pulling forward of blood is less, and that can increase your risk of chronic low flow state. In addition to that, if you have significant AV valve regurgitation, again, that could affect the forward flow in the Fontan patient, especially if the AV valve has a right-sided tricuspid valve morphology. Its ability to withstand higher pressures is lower, so it can become more dysfunctional, develop AV regurgitation, so the forward flow in these patients can become worse. And finally, Fontan circuits have passive flow, like we talked about. So low flow in the pulmonary circuit increases their risk of developing thrombus in the Fontan and the pulmonary arteries. So everyone with Fontan circuit must be on aspirin. So it's an opportunity if you have a patient that you admit with Fontan, they're not on any aspirin, look into why they're not on aspirin or some type of an antithrombotic and counseling the patient on the importance of aspirin to decrease risk of thrombus. And if the patient has arrhythmias or thrombus formation, then they should be on therapeutic anticoagulation where warfarin is preferred over DOAC. And then finally, D, these patients with Fontan circuit have a low chronic output state and elevated central venous pressure, and as a consequence can have multiple issues develop, including neurocognitive issues and renal dysfunction. One of the main issues that we talk about is chronic venous congestion leading to Fontan-associated liver disease and cirrhosis. These patients can actually develop hepatocellular carcinoma even in the absence of cirrhosis. So when we admit these patients, another opportunity to make sure that their screening is up to date. If they haven't had an ultrasound or an MRI of the belly in the last 6 months, make sure it gets done so that we can screen these patients early and treat it if needed. One way of thinking about Fontan-associated complication is thinking about it in a spectrum of Fontan failure that combines both cardiac and non-cardiac complications. Simply put, Fontan type 1 failure is essentially like HFrEF patients. Their systemic ventricle systolic function goes down. Type 2 Fontan failure is like HFpEF patients. Their diastolic function goes down. Type 3 Fontan failure is when they have preserved systolic and diastolic function, but their pulmonary vascular resistance goes up due to negative remodeling. And then finally, type 4 Fontan failure is when they have abnormal lymphatics and they can develop protein-losing enteropathy or plastic bronchitis. So thinking about all of these complications and screening for them is important. So in our patient, if we go back to his case and look at his symptoms, it's clear that he has acutely worsening hypoxemia. The combination of shortness of breath, pleuritic chest pain, tachycardia should always make you think about pulmonary embolism. But how do we reconcile a normal CTPA not showing any evidence of pulmonary embolism? And that speaks to the challenges of pacifying a Fontan circuit and the pulmonary artery in this patient. And that's because blood flow to the Fontan and the Glenn pathway can preferentially favor one of the pulmonary arteries, And because of sluggish venous flow, it can affect opacification of the pulmonary arteries. So a routine pulmonary embolism protocol isn't adequate in identifying PE in patients with Fontan circuit. So these patients should have a specialized Fontan-specific protocol that uses multi-phase acquisition, including delayed venous phase, and they have dual injection of contrast in the upper and lower extremities to try and opacify the pulmonary circuit and the Fontan circuit a little bit better to try and identify pulmonary embolism. And if it's not successful, you can think about invasive pulmonary angiogram in these patients. So quick note on pulmonary embolism and Fontan circuit. We already spoke about Fontan circuit being dependent on low pulmonary vascular resistance because of the passive flow and absence of a subpulmonic ventricle. So if you have pulmonary embolism, especially if it's large, your pulmonary vascular resistance can shoot up very quickly, and these patients are at risk of circulatory collapse. So why did our patient not present with significant hypoxemia? And that's because of the fenestration. So let's say a Fontan patient doesn't have fenestration, then the PVR goes up, the pulmonary pressure, because of the passive flow, your cardiac output is low and they become hypoxemic, become hypotensive. But if you have a fenestrated Fontan, the fenestration can act as a pop-off mechanism. Elevation in the pulmonary vascular pressure from a PE can be alleviated from a right to left shunt. And that can increase your forward flow into the systemic ventricle. And because of improvement in forward flow through the Fontan's fenestration, these patients don't present with circulatory collapse or significant hypotension. But the problem is that right to left shunt, like we talked about, worsens your oxygenation. So that would explain why our patient presented with worsening hypoxemia due to right to left shunt through the Fontan fenestration. So how do we manage these patients? I think all Fontan patients with a pulmonary embolism should be admitted to an acute care setting, like the CCU, with hemodynamic monitoring in the initial part to ensure that they're stable, that they're doing well, and early initiation of IV anticoagulation with heparin. And once they're stabilized, then they can be stepped down to the ward and then eventually transition to warfarin. If they have significant hemodynamic compromise, then they will need catheter-based thrombolytics or embolectomy as needed. We try our best not to intubate these patients because the Fontan circuit is already preload dependent, and now we're battling with elevated pulmonary pressures, and now introducing positive pressure ventilation is also going to worsen the patient's clinical state. But if it is inevitable, the intensivists use minimal PEEP possible, and never close the Fontan because the fenestration because they're hypoxemic, because the fenestration is what's preventing them from circulatory collapse. And we sort of take the worsening hypoxemia and we try our best to keep it open. And in some cases, if the pressures are really elevated, then nitric oxide inhaled therapy could be considered to reduce the pulmonary vascular resistance. So E is finally ensuring adequate follow-up. So after receiving anticoagulation, stepping down to warfarin, this patient was discharged with adequate follow-up, and his hypoxemia returned to baseline with reduction in his pulmonary pressures. So take-home points is that it's crucial to maintain low pulmonary vascular resistance in patients with Fontan circuit. In the absence of a subpulmonic ventricle, these patients are at risk of chronic low flow state and also central venous congestion. So screening for all the complications that can develop from it is very important. Have a high clinical suspicion. If they look like they're having a PE, they probably are having a PE. Get a CTPE with the correct protocol for Fontan patients and talk to our radiologist to ensure that they're aware of the Fontan, that the patient has a Fontan and they understand the Fontan physiology. So now that we've gone through 3 cases, I wanted to remind you about my simple but consistent approach. A for anatomy, B for baseline oxygenation, C for cardiac complications, D, don't forget about non-cardiac issues, and finally, E, ensure adequate follow-up for these patients. And with that, I would like to thank my congenital team for everything that they do for our patients, and especially Dr. Schwartzman and Dr. Beauchesne for all their support and mentorship, and Dr. Schwartzman for reviewing my presentation to make sure its content is correct. And I would like to thank all of you for your time and patiently sitting here and listening to me. Any questions?
Thanks. That was great, Joanne. I think we're all ready now for the congenital clinic. We'll all go and help Marcus and Luke there. On the second case, you kind of talked, oh, we'll just do it. The patient had a TE and was cardioverted, but was Eisenmenger syndrome. And I just wonder what you think about the precautions that should be done in regards to a TE on an Eisenmenger syndrome patient. Like, should we just be doing them in the echo lab? What's your thought about that?
Thank you for the question, Dr. Burwash. So patients with Eisenmenger physiology are at higher risk for cyanosis, as we spoke about, and higher risk for decompensation. This is someone I would do a TE with the cardiac anesthesiologist present. Intubating an Eisenmenger can be dangerous because of the elevated pulmonary pressures, so I would try to do it with minimal sedation with cardiac anesthesia present, probably in more of an OR or PACU setting instead of the TE instead of our TE lab. I thankfully haven't had to cardiovert a Eisenmenger syndrome myself or done a TE on them, but that would be my precaution: is talk to a congenital specialist, get cardiac anesthesia on board, and do it in a more monitored setting with minimal sedation and no intubation would be sort of my approach for it.
Well, thanks so much for this excellent talk. And maybe I should also point out that in addition of you being an echo fellow, you're now seeing some of the ACHD inpatients as an additional service. And so I think you do it now for 6-7 months. And my question to you is, based on your experience on seeing these inpatients and also knowing that you have a very busy schedule. So if you would have to prioritize which ACHD inpatients might have the biggest benefit of additional ACHD input, so which patients would you cite? Or which patient do you think might profit from your input most?
I think definitely patients with moderate or greater complexity. So TET patients, spontan patients, so moderate or greater. If they have a simple defect that's repaired and they're admitted for a non-cardiac issue, I don't think they need a congenital specialist to see them as an inpatient, but ensuring that they have adequate follow-up in some level of congenital realm, at least that they have a cardiologist, should be important. But in the inpatient setting, I think if they have a cardiac issue, and especially if they have moderate or greater complexity, if they have, arrhythmias and infective endocarditis, any of the cardiac complications that we talked about, I think it's good for us, for me, for my learning, but also for patient care from Dr. Schwartzman and Dr. Beauchene's input for them would be helpful. So moderate or greater complexity cardiac issues should be seen. And then if we have time, of course, we're happy to see simple congenital lesions. Even if they're not cardiac, it's kind of fun to go see them and talk to them.
I learned the hard way never to forget the IV air filter in my training in internal medicine. All right. Thank you very much,
Awesome.
Joanne.
Thanks, everyone.
Fantastic.